Welcome back to Forgotten Infection Friday, where we explore the infections that can hide in plain sight, but the cool ones, and the pathogens that can turn seamlessly a routine diabetic foot ulcer into a diagnostic mystery, kind of like an episode of House. So today we're going to be talking about actinomycosis. And imagine a patient with diabetes who has a chronic foot wound that won't heal, and the wound continues to drain, has sinus tracts begin to form, the tissue becomes firm and indurated, the antibiotics are prescribed, and the wound is debrided, and yet the infection keeps coming back. At first glance, it looks like another chronic diabetic foot ulcer or diabetic foot normal or chronic diabetic foot infection. What is it isn't? What is the real culprit is a slow growing invasive bacterium that can create abscesses, fibrosis, interconnected sinus tracts, and an infection that can quietly extend through the tissue planes while masquerading as much as something very familiar to us. So meet actinomycosis, okay? And actinomycosis is an uncommon, oh, let me spell it out for everybody. Actin, so actin, O, the letter O, Myces, actinomycosis, okay? It sounds like it's just from the wording, it sounds like it moves. And they did first, I believe, think that it was a fungus, but it's not, it's a bacterium. So it is quite uncommon, can cause chronic infections caused by a filamentous anaerobic gram-positive bacteria. That's what it is. And while these organisms normally live as part of the normal body's microbiota, they can become pathogenic when they breach certain tissue barriers and can be established as a deep-seated infection. So the challenge with actinomycosis is that it's incredibly difficult to recognize. It can mimic malignancy, it can mimic tuberculosis, it can mimic a chronic bacterial infection, and in patients with diabetes, it can easily be mistaken as a diabetic foot infection. But one of the classic clues is the presence of this thing called sulfur granules. And these are colonies of the bacteria surrounded by intense inflammatory response. And when the organism is hiding deep in a chronic wound, a superficial swab will miss this. It won't be able to tell the whole story. So this is why we have Forgotten Infection Friday. So if a diabetic foot wound refuses to heal, we could be missing something that is hiding underneath the wound and underneath the surface. So today we're going to continue to talk about actinomycosis, the great pretender. So why what exactly is it? We're just gonna say I already said what it is, but we're gonna go into it. It can be one of the most deceptive bacterial infections in medicine. It is chronic, it is slowly progressive, it's invasive, primarily caused by Actinomyces israeli. That's one of the species of it. That's the most common one. But these organisms are, like I said, gram-positive, filamentous, a branching bacteria. They are anaerobic or microaerophilic. And the normal flora, it's normal in your mouth flora, it's normal in your gastrointestinal flora, and it's normal in a female genital tract. But despite being a bacteria, actinomycosis behaves uniquely aggressive in an infiltrative manner. So, like I said, the infection can resemble cancer, tuberculosis, chronic osteomyelitis, and we're going to mention a case about that, fungal disease, and recurrent abscess disorders. That's why they call it the Great Pretender. Isn't that a song by, oh, the Platters? Remember the song, The Great Pretender by the Platters? Great song. I love it. So, why is actinomycosis so unique? Most bacteria spreads rapidly through lymphatics, bloodstream, superficial tissue planes. But actinomycosis behaves quite differently. It spreads quite slowly. Remember, they say slow and steady wins the race. It ignores normal tissue barriers. It burrows directly through the tissue planes. It creates fibrosis as well as scarring. It forms interconnected abscesses. That sounds interesting, right? It develops chronic draining sinus tracts, and the infection advances almost like roots spreading underground. So, this invasive pattern explains why it destroys tissue so gradually and creates these extensive undermining and recurs repeatedly, and it becomes quite difficult to eradicate. So let's do a case presentation. This is a real one. We'll talk about the real one at the end of the episode. So, 58-year-old male with poorly controlled diabetes develops swelling along his jawline and intermittent drainage from his neck, worsening firmness of the tissue over several months. So initially, he had mild tooth pain, a dental extraction was performed, and symptoms temporarily improved. Weeks later, he had swelling returned, the skin became thickened, draining opening appeared, these yellow granular material emerged from the drainage. The patient received repeated short antibiotic courses, incision drainage, and cancer evaluation. The CT revealed infiltrative soft tissue mass, extensive across fascial planes, abscess formation, and destruction near the mandibular tissue. And physicians were concerned for head and neck cancer. And there's a reason why I'm mentioning the head and neck because it's kind of one of the most common places it affects metastatic disease and chronic osteomyelitis. Okay. And so eventually they did a deep tissue biopsy and that demonstrated branching filamentous gram positive organisms with sulfur granules. Sulfur granules, like if you hear that, think actinomycosis and a dense inflammatory fibrosis. The diagnosis is going to be facial actinomycosis. And like we said, why do they call it the great pretender, like the platters? Because it mimics quite a few different diagnoses. So it can mimic cancer. So this is important because actinomycosis can create hard masses, invasive lesions, tissue destruction, fibrosis, and irregular infiltrative growth. And imaging often pairs that it could be malignant. So a CT or MRI may show these infiltrative borders, soft tissue thickening, bone involvement, abscess cavities, and enhancement in patterns resembling tumors. The tissue becomes hard, fixed, and indurated, and this leads clinicians to suspect squamous cell carcinoma, sarcoma, or metastatic disease. But many patients undergo cancer biopsies or surgical exploration or oncology referral before the infection is actually discovered. Another thing it mimics, like I said, is chronic infection. Actinomyc- Actinomycosis often resembles chronic bacterial abscesses, diabetic wound infections, osteomyelitis, hidradenitis suppurativa. We're just gonna go over that. I got tongue tied with that one. Tuberculosis. And because the disease evolves slowly, patients often have these recurrent drainage, intermittent swelling, periods of partial improvement, and relapsing symptoms over months. And the chronicity creates this diagnostic confusion. Now, another reason why it's the great pretender is cultures are frequently negative for this type of infection because, like I said, the cultures are usually fail. You need a deep tissue infection, a deep tissue biopsy. So, why do cultures often fail? Why? Because actinomycosis are anaerobic first, they're slow growing, and they're oxygen sensitive. So, the problem includes like if you do a superficial swab collection, you're exposing the specimen to oxygen. And if this is also prior to ther- antibiotic therapy, there's not inadequate incubation time. So cultures may require 2 3 weeks, right? And and then on top of that, you need to handle it with care. There needs to be special anaerobic handling of this thing, okay? Because it's sensitive to oxygen. And many laboratories discard cultures too early. So the result will be a false negative culture, a delayed diagnosis, or repeated treatment failures. So remember I mentioned the sulfur granules? This is a classic hallmark. So one of the most famous findings of actinomycosis is the sulfur granules. So these are tiny yellow particles found in the pus or purulent drainage, in the sinus tract discharge, or in the abscess material. And they resemble grains of sulfur visually. However, they do not contain no sulfur chemically. So the yellow color is simply their appearance. They like to be like the sun. So what does the sulfur granules, what are they actually? Okay. So the sulfur granules are composed of colonies of the actinomycosis organism, inflammatory granules, proteinous material, as well as calcium phosphate deposits. So under a microscope, they appear very highly characteristic. You should be able to tell with this sulfur granule. If you see that on a board, sulfur granules, that's what I would think, okay? Actinomycosis. So, how does it look under the microscope? We gave an idea, but histologically, it has a central core. The center is basophilic, dense, and composed of these intertwined filamentous bacteria. The peripheral zone, the edges just demonstrate these eosinophilic club-shaped projection, as well as these immune complex depositions. And it also has this phenomenon called splendore hopefully, I'm just gonna spell it. Splendore. So splendori hopefully. So Hoeptpli phenomenon. And this is a histopathological finding characterized by eosinophilic amorphous material deposited around the microorganism or the foreign material, and it just represents an immune mediated reaction rather than a specific infection. So you could see this type of phenomenon even in Madura foot, like in my Madura foot, mycetoma. If they do a microbial, put it underneath the microscope to give me, you could see the same phenomena with that as well. I think it's more common with that. Now, another characteristic, like we said with actinomycosis, is the tunneling sinus tract. So one of the defining destructive behaviors of actinomycosis is the formation of sinus tracts. And forgive me if I'm not pronouncing it right, okay? These are these interconnected drainage cha- tunnels, chronic access pathways, and channels extending through the deep tissue. Organisms spread directly across the fascial planes, the muscle, and the connective tissue instead of remaining localized. They are the travelers. They're like a Sagittarius. They like to travel. Why the tracks form? So actinomycosis or actinomyces causes these chronic suppurative inflammation, tissue necrosis, and persistent abscess formation. And as pressure builds, the abscesses seek drainage pathways and the channels extend towards the skin surface, and then they create these multiple interconnected tracts developing. And then over time, it's just repeatedly draining, may close temporarily and then reopen later. And this creates this recurrent wounds, chronic draining lesions, and extensive undermining tissue. Another classic feature of this infection is the woody fibrosis. So, this refers to the dense scar like hardening of the skin, marked collagen deposition, as well as board like induration. And immune system attempts to contain the infection. That's what the your immune system, your body will always try to contain the infection. That's why we see it with a lot with the foreign body, right? It tries to localize it so that you're not moving forward with my person. You're not going to destroy my person's entire body, right? Your body literally does try to protect you, but the infection persists chronically. So the fibroblast becomes activated, the collagen accumulates, and scar tissue does thicken progressively with this infection. And tissue eventually becomes extremely firm, immobile, and hard like wood. That's why they call it woody fibrosis. So why did I mention this? Why does the woody fibrosis matter? So this feature strongly contributes to cancer confusion because the hard infiltrative neck lesion that may appear identical to something that they may diagnose as an invasive carcinoma, metastatic adenopathy, forgive me, a desmoplastic tumor reaction, and the fibrosis also limits as well. It limits antibiotic penetration, immune cells immune cell access as well as drainage. And this contributes to the chronicity, the recurrence, and the prolonged treatment required. And so let's talk about the common clinical forms of this forgotten infection. So cervical-facial actinomycosis, that's why I mentioned it. That's the most common one. It often follows dental extraction, tooth extraction, oral trauma, or poor dentation. Features are jaw swelling, neck mass, draining sinus tracts, sulfur granules, and mandibular involvement. They call it lumpy jaw. Thoracic actinomycosis occurs after aspiration of the oral secretions. It can mimic lung cancer, tuberculosis, chronic pneumonia. Features would be cavitary lesions, chest wall invasion, pleural extension, chronic cough, weight loss, and infection may cross the tissue planes into the ribs, the mediastinum, as well as the skin. So this aggressive spread is unusual for an ordinary bacterial pneumonia. Pneumonia. So another common form of this disorder is the abdominal actinomycosis. So it's associated with bowel perforation as well as surgery, appendicitis, and diverticulitis. And the features would be abdominal masses, fistulas, chronic abscesses, bowel wall thickening, often mistaken for colon cancer, Crohn's disease, and intra-abdominal malignancy. Another one is pelvic actinomycosis. So this is associated with prolonged IUD use. So features would be pelvic masses, abscesses, fibrosis, or tubal ovarian involvement that can mimic ovarian cancer or pelvic inflammatory disease. So what is the gold standard for definitive diagnosis of this? So diagnosis requires a high level of suspicion. So a tissue biopsy. The best diagnostic method for this is a deep tissue biopsy. Remember we talked about superficial swabs being inadequate for this type of infection? Why? Because the surface cultures will become contaminated with the normal flora, but deep tissue will allow visualization of the bacterial colonies, the fibrosis, the inflammatory architecture, as well as the sulfur granules. And like we said, what would the histology see underneath the microscope? You will see these branching filamentous gram-positive bacteria, these tangled bacterial colonies, the suppurative inflammation, and these dense fibrosis. And historically, the organisms were called ray fungus because they are radial microscopic appearance. However, it's not a fungus, it's a bacteria. And remember, we talked about the sulfur granule being present and cultures. Like I said, cultures can remain confirmatory when it comes to this, but it's not really recommended. But it can be challenging because it requires anaerobic or microaerophilic conditions, prolonged incubation, and careful specimen transport. And the growth requires 2 to 3 weeks. So common reasons for a culture coming back, like a regular culture coming back as a false negative for this bacteria is oxygen exposure, prior antibiotics, poor specimen collection, and insufficient incubation duration. Now, you can also do the gram stain. It's just going to typically show a gram-positive branching filamentous rods, intertwined bacterial network. This finding does help differentiate actinomycosis from other infections. And we talked about why it's often missed. So let's differentiate it from an ordinary bacterial abscess. So typical bacterial abscesses are going to be acute, painful, localized, and rapidly progressing. Actinomycosis is chronic, invasive, fibrotic, tunneling, and recurrent. Also, you have to put it against cancer. Remember, cancer biopsy is going to show malignant cells, dysplasia, uncontrolled neoplastic growth. Actinomycosis is going to demonstrate inflammatory tissue, bacterial colonies, fibrosis, and abscess. So, what is the treatment for this? Long-term antibiotics. Why? Because remember we said this organism is slow growing, invades deeply, becomes trapped within the fibrosis, which allows it makes it harder for the antibiotics to penetrate it and forms poorly penetrated abscesses. So treatment, therefore, is much longer than normal infections. So what is the first line therapy treatment for this? High dose penicillin. IV at IV penicillin initially for severe diseases of this, followed by prolonged oral therapy. Treatment duration may last weeks, sometimes it even lasts 6 to 12 months for extensive disease of the severity. Alternate antibiotics for this, if the patient has a penicillin allergy, doxycycline, clindamycin, macrolates could be used, and then surgical management. So some patients will require abscess drainage, excision of the sinus tracts, debridement, removal of necrotic tissue, surgery. is essential, especially if there is extensive fibrosis, a large abscess does exist, diagnosis is uncertain, or malignancy must be excluded. So, I would just think that if they think about this, think of chronic draining sinuses, because you can think of Madurafoot, macetoma, forgive me, sulfur granules, hard fibrotic mass, recurrent abscesses, jaw infection after dental diseases, tumor-like lesions with negative cancer biopsy, and cluster pearl. I would just remember the sulfur granules and the woody fibrosis, and that it is the great pretender, like the song from the Platters. So there is a actual case report of it, but it was in 1987, okay, of osteomyelitis of the foot by actinomycosis or actinomycesis myeri. That was the species of it. It's extremely rare, right? Because it's normal in mouth flora, but they had a case of anaerobic osteomyelitis from this, okay? So in the end of all of this, it is very interesting infection, very rare. It is a chronic invasive bacterial infection caused by a filamentous anaerobic gram-positive organism that normally inhabits the human mucosal surfaces. But once the tissue barriers are disrupted, the organism can spread slowly and relentlessly across the tissue planes, producing abscesses, fibrosis, sinus tracts, granules, sulfur granules, as well as destructive infiltrative masses. Hallmark of features of this infection is chronic cystity, woody fibrosis, sulfur granules, the tunneling sinus tracts, and tumor-like behavior. The disease is often misdiagnosed because it resembles malignancy, tuberculosis even, chronic inflammatory disorders. And definitive diagnosis would be deep tissue biopsy, histopathology, as well as anaerobic culture. Treatment requires prolonged antibiotics, possible surgical drainage and debridement, and careful long-term follow-up. So I hope everybody liked this episode of Forgotten Infection Friday by Diabetic Profiles. I'm Dr. G, and take care of your feet because they take care of you.